each of them. Now, Dr. Vikram Jain is going to talk. He is the Chairman Scientific Committee, Karnataka Ophthalmological Society, also fabulous phaco surgeon. So he'll be talking about how I deal with dysphotopsia. Over to you, Dr. Vikram.
Thank you, Dr. Kudlu. So let's discuss about dysphotopsia, the types, and how to go about doing this. Our entire session is about a good surgery but unhappy patients. Why? Dysphotopsia is one reason. Now, when I'm talking about dysphotopsia, I'm not going to highlight about the halos that we see in multifocals or trifocals, because we all expect this pre-op. There can be some unexpected changes, unexpected symptoms post-operatively. Let's try to look into what they can be, why, and how to go about them. So dysphotopsia are undesirable and subjective optical phenomenon. They are subjective. There are no objective tests to detect or quantify these. They can either be positive or negative dysphotopsia. They are only diagnosed when the patient complains of them. There are no objective tests. It is important that we distinguish these symptoms from probably some retinal vitreous traction which is producing some flashes, or a striae in the posterior capsule which is giving the Maddox rod effect. So make sure it is not these, and there is something else, other symptoms which we can't attribute to anything else. Positive dysphotopsia is when patient complains of seeing excess light, extra light. Negative is when there is a dark shadow. There can be different types of positive dysphotopsia. The common ones are the arc, which is when the patient perceives the edge of the IOL. This happens with a bigger pupil size, so therefore after evening. It generally recovers over time, especially if the capsule has overlapped the IOL edge, then this arc decreases within a few months. Flare comes with minor cylinders and a coma. Correcting this very minimal cylinders, 0.25, 0.5 also helps in these patients. Later on, once the patient adapts to it, these glasses may not be required. For all these positive dysphotopsia, making the pupil smaller at night definitely helps. Central flash is when the patient suddenly sees a glare because of reflection, internal reflection at the edge of the IOL. So you have the internal reflection there within at the edge, which comes as a glare, sudden central flash. The patient might perceive that. Starbursts are caused because of backscatter, again a form of internal reflection from the lens, along with some eye movements which trigger these. Halos I already told that I'll be skipping it because we know why they occur. That's because of differing refraction at each edge of the multifocal IOL. These positive dysphotopsia are seen more commonly with square edge IOLs. Oval optics, which are now, I think there are some Indian innovators who have come up with the recent oval optic. Earlier, Masket had an oval optic which was then abandoned for this reason. Also with higher refractive index like the IQ is very, very prone to positive dysphotopsia. To overcome these, manufacturers made some changes. There was a rounding of the anterior edge and lenticular design. So here you see a much thicker IOL. In lenticular design, the edge of the IOL was thinned out. These definitely helped, and the positive dysphotopsia numbers dropped. How to manage these? If there is any refractive error, I told you about the coma, correct it. If there is PCO, treat it. Otherwise, a YAG would never help. Meiosis in the evening, just a single drop of pilocarpine every evening initially will help. In case of high refractive index lenses, you might have to exchange the lens in case it is not coming down. What is negative dysphotopsia? Negative means that the patient is not seeing something. There is a dark temporal crescent. This incidence is very high initially. In the first 2 weeks, generally the patient has the wow effect immediately after surgery. When you see him on the third or fourth day, the next time he comes, he'll start complaining about the temporal dark crescent. Why is it temporal? There are two schools of thought. One is because the nasal retina extends a little more anterior. Other one is that the bridge of the nose cuts off the light coming from the other side. Now these negative dysphotopsia will be worsened by constricting the pupil, whereas positive, I told you, you can constrict the pupil, therefore don't constrict the pupil for a dark shadow. This negative dysphotopsia is associated with any incision, temporal or superior. It is associated with any IOL which has been placed in the bag. It is not seen in sulcus or AC IOLs. It is not seen in poorly centered lenses. Basically, if a patient is complaining of this negative dysphotopsia, it's a pat on your back that you've done a anatomically perfect surgery. It is seen only in anatomically perfect surgeries. Otherwise, if it's imperfect, if the IOL is not centered, this is not seen. It is seen more commonly in higher powered IOLs as well as lenses which I already mentioned, higher refractive index. So this is how the patient would complain. There is a dark shadow. This is a left eye operated, so on the left side there is a dark shadow on the temporal aspect. There were two schools of thought as to why this is happening. Holiday said this is an edge penumbra, and Masket said it is because of the relatively deeper IOL. So this is an edge penumbra wherein there is some refraction happening, some reflection happening. So there, like an eclipse, you are seeing the dark area. Again, with round edge lenses, this penumbra is thought to be less, but then this negative dysphotopsia persists. That's why Holiday came up with his theory about the position of the lens. So here this arrow is showing that how the internal reflection occurs, and therefore there is a penumbra there. So what Holiday said was that because of this distance, the anterior capsule is supposed to be here. Earlier there was not much of distance. Now it is much more, the distance there. There are unrefracted rays going through. So because there are unrefracted rays going through, you have this area with no light falling there. So how do we surgically manage these patients? One is to put a piggyback IOL in the sulcus. You are going to be cutting off some aberrant light pathways there, or doing a reverse optic capture by getting the optic into the sulcus, keep the haptics in the bag itself, or reposition the entire lens in the sulcus. Holiday also had Masket had designed a dysphotopsia IOL with a small edge there where the anterior capsule goes and sits there, so that the lens is maintained little anteriorly. But most of the time, masterly inactivity is the best. In my initial slide, I showed you that 35% of our patients will complain of this at 1 month, but it decreases to 3% by the end of a year, and even lesser in longer follow-up. We all don't see our own physiological blind spot. There is natural backscatter of the natural lens which we don't perceive, as well as the retinal blood vessels. We adapt to all of these. Similarly, this negative dysphotopsia also disappears with time. Very, very rarely do patients complain about this over a period of more than 1 year. Thank you.
Thank you, Dr. Vikram. I think most of us really were confused with the glare and halos with the dysphotopsia. So we tend to give them lubricating drops. We tend to give them, of course, we always wait for the neural adaptation to happen. In your case scenario, do you have any patients with the dysphotopsia? Really, you had a chance of explanting the lens?
Not really. Not explanted a lens for the dysphotopsia. As you said, lubricant will work if to correct any ocular surface, and most importantly as a placebo. The lubricant will act like a placebo. They'll think that, okay, doctor is doing something, he's added something extra, and when it gradually decreases, they will also stop complaining about it.
Yeah, for every patient, you have to give a time for neural adaptation. See, you have seen patients with complaining of this kind of starbursts and all, but after 1 month they'll tell, पहले से थोड़ा कम हो रहा है. Then when they come for a second follow-up after second month, they'll tell, now I am getting better because of drops. As you said, that placebo. And the most of the time, 99.9% of the patient, after the end of 3 months, they say that now I'm absolutely all right. So you have to give, and I think counseling is at most